So good morning again. I'm Dr. Bacorro. Thank you again for attending the interdisciplinary collaborations and communication lines, the key towards palliative care holistic approach. This is a collaboration between the Medical Center Department of Family and Community Medicine and the Mary Johnston Hospital Department of Family and Community Medicine Practice-Based Residency Training Program. So actually, I'll be tackling about community palliative care. In so doing, I'll be sharing what we have started in the Medical Center. Okay, wherein I'm currently the head of the service, the community palliative building blocks for level 1 palliative care provisions. So as for your orientation, the provider-based model for primary, secondary, and tertiary palliative care staff, the model focuses on palliative care services according to level of patient complexity and setting. So primary palliative care can be provided by primary care providers, oncologists, and others. Secondary palliative care is provided to patients with more complex needs, and they may be referred to a specialized palliative care team. Uh, while tertiary palliative care is indicated for patients with the most complex supportive care needs, often in academic centers. So as you can see here, no, the expertise in palliative care elevates while going in the uh, peak of the triangle. Okay, so for public health awareness, the old concept of or the current practice of hospice and palliative care is that curative treatment would be maximized first and then being referred to palliative care, which eventually will be leading to hospice care and bereavement care. So continuum of care, however, proposes that the palliative care works hand in hand while doing the disease modifying treatment. Okay? So in Tondo Medical Center or the management core team, first of all, would be satisfied at that the core set of supervisor would be a palliative specialist and one palliative nurse head or rotating FM resident in the service. A multidisciplinary team of referral system or blanket referral has been introduced already since March, wherein the oncology doctors, the surgical onco, medicine onco, radiation oncology, gynecology, pediatric oncology, etc. comprise the anesthesia pain management collaboration and other departments referring chronic patients who have debilitating conditions would be futuristic. The service provisions in the medical center are of two kinds: the primary palliative care services, wherein the biopsychosocial needs of the index patient and the family, which are actually the uh, which are being addressed actually by the family medicine service or department rather, and their assistance to palliative care consultant, wherein service referrals would be initially accommodated by them, and they will be making daily rounds as per the palliative care consultant supervision, and the rotator will act as the preceptor of the subspecialty management and collaborative management with multidisciplinary team per guidance of subspecialty consultant is being applied. Subspecialty services wherein symptom management of complex palliative cases referred is being addressed I am also the service director and manager, and the training of primary palliative care residents and service rotators are actually my task. Education of undergraduates are also included, and the attendance to multidisciplinary conferences and approval of collaborative management with other primary care services are being applied. So why community palliative care? So we should be tackling several strategies that has been practiced by other successful long-term care um, services in India, okay, in Kerala, and other successful countries like us, wherein awareness, involvement, collaborative aspect, the application of discipline, trust issues, quality of care dependency, provisions of service, team player status are being applied and integrated. So for awareness, so every novel concept and emerging discipline starts actually within. Every public health awareness starts with health authorities being united in a certain belief that such novel concept, such as palliative discipline, is essential and applicable in the setting we are in. So to attain social relevance, we need it best to incorporate the concepts in the practice. Roads to awareness involves basically the following topics. First, you should elaborate on the conceptual definition like what I have done a while ago, terminologies and technical aspect. So these are being discussed starting from the undergraduates. Okay, so schools of thought, the perceptions being applied, history and origin, practical applicability, services provided, specialized skills, the execution of competencies, social importance and relevance, quality of life importance, anticipatory guidance to common misperceptions, of course, and establishing a practical profiler, importance of the discipline. So for the involvement part, the advocacy drives actually involving different disciplines such as public health lectures, collaboration with different disciplines and departments, initiate camaraderie and curiosity to other healthcare professionals. This is actually an eye-opener that teamwork is necessary in end-of-life management, terminal and poor prognosticated disease entities and conditions. So here, you can see that we already started a service. Collaborative aspect for effective collaboration to exist, we should start slowly, but actually, of course, sure. Okay, be keen in satisfying the two targets, as we have already discussed. Introduce significant questions in mind of the other healthcare workers, and we should assert the position in the multidisciplinary team, of course. So we should be patient enough to hurdle possible difficulties at the start and be humble enough to anticipate possible differences in beliefs and practices. Most of all, validate culture, address emotionally critical misperceptions. Once you have been given the opportunity to prove yourself, then take it with the readiness of working double time since the specialty is actually new and inevitably involves cases which might be controversial and or contradicting superficially to traditional beliefs. uh, there is also a conceptual framework which I have initiated applying the principles, no? So highlighting on the support system for palliative care team as well. As you can see here, We work hand in hand with psychiatry and psychologists, okay? And the occupational health supportive core group, wherein uh, they cater to the needs of the employees, which in turn would be um, practically applicable also to the palliative care team. Hence, they would be addressing the biopsychosocial part needed by the team. Okay, so the core team members of the palliative care team would be addressed, however, by the acute psychiatric unit as a psychosocial need support. Okay, so this is blurred, but this slide only tells that we do collaborative practice among different departments, with different departments rather. So we establish the goals of care, advanced care planning, and other anticipatory guidance discussion with the index patient and family being referred to us. So for how to inculcate discipline, maximize present status, workforce, finances, present situation, and integrate whatever is applicable, no, in the present level. Of course, we have to set realistic goals, be consistent, initiate resiliency and forbearance, and develop the right attitude. So, establishing trust and reliability. So, we should take seriously all referrals, no matter how seemingly simple and difficult, necessitating all patients rather existing in you, no, we have to remember that at the start, it is inevitable that we accept the most challenging situation, since usually the other departments have difficulty in dealing with that certain scenario. That's why they have referred to us. This should not deter us, but instead convert them into opportunities and accept these difficulties as part of our specialty. Elaboration of bad news disclosed, management after all life-saving modalities have been consumed, and navigation are actually some examples. Quality of care dependency. Always intend to provide quality of life services once being referred to, highlighting that aspect of care that we intend to provide. That's why we also need the continuous medical education training, and uh, not only theoretically but practically. So provisions of service specific to the specialty or discipline. Execute core competencies and skills in the most unique and skillful way possible that will highlight our difference from other services. Of course, holistic care being consistently done with the right attitudes should be reminded among our cohorts and be points of evaluation. And we should always maintain a team player status. Always emphasize that palliative care is being executed best as a team. Know your limitations, work hand in hand with other departments or collaborating services. So as you can see here, this is the actual scenario in the medical center. We discuss cases. We work as a team. No, we attend multidisciplinary meetings and do by intensive biopsychosocial counseling with the involved index patient or their families. So there should be short uh, term initiation phase and planning, wherein aims, targets, methods, activities, and expected outcomes should be properly planned. Okay, the stabilization phase also. So for long years or long-term goals, for the maintenance phase, no? So this is your actual goal in the long-term future, which will be requiring tremendous work. So strategies to improve the awareness in your local community and the need for palliative care in the region. I'll be sharing with you the 15 effective strategies for a 60-day period coverage. So this has been presented actually in um, homework in the palliative masterclass or Institute of Palliative Medicine fellowship. So strategy one would be to know your community or the demographic analysis. So knowing your community will easily incorporate the way you will be encouraging everyone in the community later on with the community activities. Strategy two would be to know the felt needs of the community pertaining to the palliative care discipline. These addresses emotionally critical misperceptions as we have known before and been discussing from time to time, which are the actual beliefs, culture, and practices that might impede the acceptance of the palliative care discipline. Um, Feasibility can be a 2 months period. Methodology would be to make a survey stating common barriers towards palliative care. So actually, it's a SWOT analysis. Okay, so you can do Likert scale. The survey can be administered coinciding with from the medical center. We do mass vaccination, so we can also administer the survey in there, correlate with demographics of respondents, and make an output based on official report and derive data summarizing the barriers. So for strategy three, so here are concrete steps. Okay, so address felt needs from previous step uh, that are actually modifiable or addressable. So examples of these include the following needs. Morphine drug addiction, referral to palliative care means surrendering hope, last resort when all means are depleted. Feasibility in 2 months, yes. How? Incorporate in the CEA method of counseling, wherein we'll be tackling in the lecture workshop later. Education here give provisions for addressing aligned perceptions, therefore clarifying things in 15 minutes. So other activities to empower the said activity would be to include and involve the index patient and the family with other index patients and their families through group therapy activities or advocacies. And we can send flyers and basic information dissemination through frequently asked questions. Strategy 4, accessibility for inquiries or inquiries. So set an open stance for referrals and be flexible since the strength of the palliative care team is actually their psychosocial competencies and exposure. Professional members and all the members of the palliative care team in general has this competency as common ground. This skill, however, is not inherent in among other departments, hence bulk of referrals concerning awkward scenario elaboration of bad news, dealing with psychosocial issues of family and other matters pertaining to these, lead the other departments to the family medicine and primary palliative care, and of course the palliative care service, sometimes causing a total number of census to challenge and burn out of palliative care team workforce. So we should make an individualized set of plan that will address the bulk of referrals, consisting of maybe group therapy, volume therapy, focus group discussion for similar cases, and family meeting, wherein allocation of works should be done accordingly. For strategy 5, we should propose acceptance of volunteers, no, with the administrative body, no, since recognition of the discipline's importance and service provisions, needing this set of volunteers will make things a lot doable and allocate properly well-preventive burnout measures to keep the programs. Um, that is approving acceptance of volunteers. No, hopefully, for tantamount to community palliative care, which starts at the hospital institution, especially for compassionate skills training. So, strategy 6, so inculcating the discipline among medical students. Start slowly and go slowly by incorporating the palliative care subject among the fresh-minded young students, rotators, set role-playing activities and process them, set the subject as part of the curriculum in med school or at the postgraduate interns clinic rotation in the hospital or institution you are in. And sets strategy 7 rather, collaborate with public health department. Since public health information dissemination through providing lecture series among the lay population is still part and parcel of the discipline. Strategy 8, set collaboration and alliance with other department. Of course, we should attend multidisciplinary meetings proactively. Then maximize the time allotted for your department to expound, no, on your perceptions on the case, support advocacies, capacity building in standardization of lectures, 2 months for skills training and capacity building for volunteers based on the guidelines being provided not only by DOH but also by the WHO will instill in them a sense of belongingness and compassion with the discipline. This will potentially engage their commitment as volunteers. So as you can see, there are also caregiver trainings that are necessary. Okay, so train the trainer series sessions. Setting trainings will boost the volunteers' confidence and inspiration in the importance of their roles in the discipline. So, do a rewards program for volunteers. So, at least this is a factor wherein you can empower them also. So, they should be better collaborated with the LGUs. For example, if possible, no? Educational scholarships or work opportunities or pregnancy package, all depends from what is feasible in their locality. So, strategy 13 would be to set an adapted community where volunteers provide compassionate quality services. So there's a target community in connection with the church where initial meeting was done and service provisions are actually under the approval process of terms and conditions. Primary palliative care team and PJIs under them, and the trained volunteers shall be the manpower in this strategic step. Of course, with the supervision of the residents and consultants also. So, strategy 14 to provide for our adapted community, gather help in setting up consistent funding, of course, from NGOs and other philanthropists by involving them in advocacy programs or emphasize goals, especially aligned with their intentions as various stakeholders. So lastly, for strategy 15, evaluation programs, projects, and deliverables periodically, regulate periodic monitoring of all activities of the department, identify SWOT analysis, and update regularly the following: what to maintain, what to continue, and what to change. So in closing, all the above points should be highlighted as practices of um, our palliative approach that will eventually encourage their healthcare workers and be inspired to volunteer without hesitation in becoming members of the team. Taking pride in what you do and actually striving hard to execute best the embodiment of the core principles of the discipline will provide a domino effect. The action-reaction formation infecting others to be one of us. So here is our self-care. So last rather, but not the least, nothing is impossible with God, of course. Thank you. So for any questions, I'll be entertaining in 5 to 10 minutes. Thank you.